Hello, viewers, and good evening. 10th of every month, and this is Dr. Neena Malhotra, Chairperson of the Imaging Science Committee, coming with yet another podcast. Before we really go into the podcast, I think I take pleasure in welcoming our President of Fogsi, dear Dr. Sunita Tandulwadkar. I don't think she needs an introduction, such a celebrated gynecologist and a woman with dynamism and passion who leads this mission called the Gyan Pravah, the podcast series. So, welcome, Dr. Sunita, to yet another podcast, and we'd want you to bless this episode as well.
Thank you, Nina. Thank you so much. And Nina, we are going to miss you in Sampurna. It's going to be one of the biggest conference of the year. Anyway, Dr. Ramesh Agarwal, sir, thank you so much for joining and giving your time to this Foxy podcast series. I think today it is some 287, 88. For last 288 days, we are 8 p.m. entire Foxy the committee chairperson, they are so particular. So on 10th of every month, Nina will be there. And we have always, either it may be academic, but even we have a lot of non-academic, philosophical, spiritual, social, political backgrounds. And I thought these are just to give the complete leverage to the chairperson because they are the future leaders. Our organization works. The entry point is chairperson and exit point is a Foxy presidency. And then you retire from Foxy. Of course, you remain with your interest because our goal of maternal health is going to be there lifelong. But believe me, more than my chairperson, I'm enjoying this podcast because get chance to meet so many faculty, so many achievers, so many people who have done such an extraordinary work in their field. And it is always pleasure to meet them and learn a lot from each and every individual. We come out of our bubble of OBGYN. We realize world is more beautiful and there are a lot many people who are doing lot of work. So thank you for your time once again. Our protocol is I join the viewers link and you and Nina will have a beautiful dialogue together. So thank you. Thank
Thank
you.
you. Thank you so much.
And I read your CV, which Nina has shared, and it's amazing to know you. And probably you will be climbing up on a central government. Don't forget us and don't forget Foxy to help Foxy.
Ma'am, just two comments. One is thank you very much to you and Foxy and Nina, ma'am. It's wonderful to interact with the members of Foxy. And as I keep saying, though my wife is also an obstetrician, she's a professor of gynae ops at Maulana Azad. But my own conviction is that it's all about mothers. I believe it from the bottom of my heart. You know, newborns are nothing without mother. It is, we all should be focusing on mother's health without any doubt. And thank you very much for this opportunity.
I agree with you, Dr. Ramesh, because my one very important project, which even the government knows and many state government knows, is Sampurna, the preconceptional care. I always feel the lady is carrying a baby, 9 months journey, and she need to be fit. So my main project is Sampurna, which is preconceptional care to optimize maternal and neonatal outcome. And I'm aware how we have a SDG goal of below 70 by 2030. Probably every neonatology department is working to get into single digit as much as possible.
Absolutely,
So,
ma'am.
yeah,
Absolutely.
so we all work with the same goal, and it will be always great pleasure to listen to this beautiful, interesting podcast where one side is the head of the department, AIMS, one of the most reputed institution of the country, and one side will be Dr. Agarwal, the neonatologist. So I think it will be great to hear. Thank you. Thank you.
So yes, viewers, so November is recognized globally as a prematurity awareness month to raise awareness of the preterm birth and also to highlight the challenges that are faced by preterm babies and families. So basically, we're trying to advocate for better care, better support, not just to the preterm, but the affected families. And for this, podcast, what could I have asked? Nobody less. And no, and the best person is here, none other than Dr. Ramesh Agarwal, who's a professor of pediatrics at AIMS. He leads the neonatal division and the WHO Collaborating Center at the prestigious All India Institute of Medical Sciences, New Delhi. For over 2 decades, he has advanced newborn care through clinical service, research, education, and policy. He established the Indian Neonatal Sepsis Research Network, which revealed how sepsis in low middle income countries is distinct and shaped the understanding of infection patterns, antimicrobial resistance, and practical solutions for hospital. He currently leads one of the most ambitious implementation research project which achieves a single digit neonatal mortality in an Indian district. I think if you name any national, international collaborative project in neonatology where India is represented, Professor Ramesh Agarwal you will find his name there. With over 300 publications, he's guided numerous projects on kangaroo mother care, quality improvement, infection prevention, and healthcare innovation. He's working globally to improve the neonatal outcome survival. And I think that's how I would introduce my colleague and a friend who we really fall back whenever we have any high-risk mother come in. So thank you, Dr. Ramesh, for agreeing and being on my panel. So I think let's set the ball rolling. I think I won't highlight figures that I would do. I think you are the best person because even if I take it from the chat GPT or the, whatever site, you will still give us numbers beyond that. So just to begin, how common is preterm birth and how do you look at it globally and in India? And in that perspective, how do you feel are the problems of this? How
First
common
of
is it?
all, thanks very much, ma'am, for this opportunity, and good evening to viewers. And it's my privilege to be able to interact with Foxy members. And as I said, that it's all about the mothers, and we all, whether we are taking care of the mother or newborn babies, we should all keep mothers at the center. Uh, that should be the bottom line. Coming to the preterm births, we have approximately, if you look at the global average, then that's around 5 to 15% or something, with an average of 10%. So if you look in terms of absolute numbers, then nearly of the 150 million births that we have world over, 15 crore babies born, to almost 35 million would be preterm births. And if you look at India, then nearly 13% babies are born preterm. And if you look at the death toll, then 40% of all the neonatal death would occur due to prematurity related complications. So therefore, it's the number one cause of neonatal death, and therefore very important for the families, for us doctors, and for the nation. You're
Given
muted.
us with you've given it very crisply. But then I just want to know, because this is a podcast which is watched by lay public, so you think that there is a concern, and why should we really be concerned about any baby coming out preterm? And how would you rate it? Is the concern more, and is it something more depending on the gestational age, or it's like overall the same, because giving the message to our lay public as well?
Right. So if you look at the preterm births, then as I said, 1 in 10 babies approximately. In India, a little more actually, 1 in 8 babies or something would be born preterm. And if you look at the causes of death, then 40%, 4 out of 10 neonatal deaths would occur due to prematurity related complications. So whenever you have a preterm birth, it's kind of a crisis for the family. Family undergoes the immense amount of stress. It requires long-term hospital stay. There is always fear, anxiety, whether our baby would survive or not. And then there are concerns for long-term issues. And of course, cost. Cost is particularly for very small babies can be really very exorbitant for the families.
So really, I think it's a toll on the family when the mother's going in labor, and we know there are challenges right from respiratory distress to baby staying in the NICU and all the problems that are on. So when you get a call, I think when we're bothering you, and I know your team is fantastic, how they've taken care of it. What goes about in your counseling such parents? Because we know that some may pull through. We may take them with, taking preterm. But what are the ways you would sort of, talk to the family, talk to the parents? How would you take this family in the first few hours and the first few days? Or I would say while the mother started laboring and we know there's an impending preterm birth.
Right. So, when a preterm baby is born or about to be born, then there is a lot to be informed to the family. And therefore, everything cannot be conveyed in single go. I think the first and foremost objective when we approach the families to establish rapport with the family so that they get to know us and we know them, that who all are there in the family and what are their concern, what kind of socioeconomic background that they are coming from. And then I think the first thing that we would like to do is to assure the family, because this is something they are already undergoing through many negative or draining emotions. So assuring the family would be very important. We'll tell them that we are there, we'll take care of your baby, and most of the babies would survive. And once they are at ease, then we gradually tell them that what is the care likely to be, what are the chances of survival, what is the therapy that we would do. Fortunately, care is free in our hospital and in other government hospitals, but the centers that are have to charge money, they need to talk about the expenses also and expected stay. And as the baby, as the stay prolongs, then we keep talking to them on different issues. It's like an obstacle race, one thing come and then, the other thing, and then we get over. Then we try to sensitize them that it's going to be a bumpy journey, but we will get over.
I think it's a lot of dialogue that goes between the family, the mother.
Yeah.
You all really allay a lot of their worries and fears. Now, we know there are problems. There's one side, respiratory distress, there's hypoglycemia, hypothermia, all the likes of complications that we know. But once you made it, once you know that this baby has come out of the woods, how do you how do you define the trajectory of growth of these babies once they are done the few difficult hours or the difficult time, and how do they develop over time? I would say, how do they fare in their milestones in the earlier months or the early year in the first year? We know that it takes a lot of cause for the under one mortality preterm births, but then once they're there, how do they really catch up on their growth in terms of your
So,
observation?
I'll take the first part of your question first. Not all the preterm babies are the same. If you look at all the preterm babies, then 75% of them are late preterm, 34, 35, 36 weeks. And these are the babies with good antenatal and intrapartum care. Um, we are lucky to have a great obstetric department, like, use of antenatal steroids and in general care during birth is very, very critical. So these 75% of the babies with good antenatal and good intranatal care and care at birth, their journey is rather smooth. And what they need simply is in our setup, they would simply be put on in the warmer, or even if the baby is more than 1.8 kg, then the baby would go to the mother also. And what these babies need is simple care like warmth, KMC, breast milk feeding, taking care of the mother, prevention from the infection, etc. And they would do quite well. Then comes the second group of the babies, 28 to 31 weeks, and we call them very preterm neonates. In between, you have 33 and 32 and 33 moderately preterm babies also. They can sometimes behave like very preterm, and many a times they would also behave like late preterm. But then these babies are more likely to stay in the NICU. And when we look at the very preterm babies, 28 to 31 week babies, and if they have received antenatal steroids, 20 to 30% may require things like surfactant, intensive care, ventilation. Often these babies would do quite well with CPAP. And once the baby is 4 or 5 days old, then they tend to follow the trajectory of moderate to late preterm in units. When it comes to extremely preterm babies, less than 28 weeks, then it's a different ball game. It's a very, very intensive care unit, and these babies develop variety of complications, and they require intensive care and very long stay. And you have to work with the families in a totally different way. And their hospital stay would also be variable. So while the bigger babies may require shorter stay, maybe a week or a couple of weeks, very preterm babies would require stay of months together. And we try to keep the feeding and nutrition at the center because that benefit the baby in many ways. And mother's milk feeding would be the most important. So working with the mother and the family would be very, very important, and care of the mother would be very important so that she's able to give milk. And the early part, the babies may require PN, parenteral nutrition, etc. And if you keep growth at the center, then majority of these babies would do quite well.
That's important because I think the bigger challenge comes when these preterms are also bound with an SG element. There's the growth restriction. So I feel that would be definitely a challenge. But so if we look at an SGA vis-a-vis a preterm, how do you see their growth trajectories later in their development? I mean, do you feel
Yeah.
it's the same or it's different? Because I thought this is some aspect which we always need to talk when the mother has an SGA. But I think that was what I thought we can ask you again. How would you see that?
Yeah. So it's a very interesting thing actually, and I'll take this opportunity to clarify one very important concept. Let's say you take 1.2 kg baby, and this baby, one you have SCA baby, another is AGA baby. So which baby is going to fare better? So it's an SCA baby that is going to fare better because SCA baby is more mature. This baby is likely to be 5 year gestation compared to an AGA baby who is likely to be a lower gestation, and gestation is more important figure. So 1.82 kg, sorry, the same weight, SCA baby is likely to do better. Now you take same gestation and let's say a 33-week baby, SCA baby and AGA baby. SGA baby would weigh lesser, and compared to an AGA baby, this baby would fare much lesser. And if you look at the growth trajectory, we tend to have two kinds of SCA. One is what we call as symmetrical IUCR, wherein the insult is early on or the genetic potential of the baby is lesser. So then these babies stay small all the time, even in their follow-up 2 years, 5 years, 6 years. Their growth outcomes are suboptimal because the insult has been very early. For the asymmetrical IUGR or SCA babies, the insult is late and length and SC is often preserved. So if you can take care of nutrition and the developmentally supportive care and nurturing care, as we call it, then these babies would catch up and would achieve their genetic potential. But the team has to, within an ICU and beyond an ICU, perhaps much intensively beyond ICU, that you need to work with the family. And complementary feeding is a very, very challenging issue unless you educate the family. There are problems. But if you take care of them, then they tend to have much better growth outcomes. But if you look at the overall, all these babies do much, they tend to, the postnatal growth restriction persist in many of these babies.
And I think that's what we need to kind of understand while we are talking and counseling to the parents, and also future neurodevelopment. I think milestones are so pertinent. Um, I, I think again, most of the preterm births occur idiopathic or unexplained, but I think we have identifiable cause. I think infection remains the lead cause when it's maternal infection. And I know that when there is a maternal infection, it is a reason for the baby to be born premature. So how do you see the element of a new preterm baby coming from a mother who's infected or she's got, even if we try to thwart the infection, give antibiotics, how do you see their outcomes with somebody who comes with no
Mhm.
infection? How does that management and the outcomes matter?
So you rightly said, ma'am, we can broadly classify preterm neonates into, or prematurity, preterm labor into three broad groups. Preterm births or labor remains a heterogeneous group. Uh, and we can only talk in terms of risk factors. For sure, we really do not know what's the cause for preterm labor. So one group is the group where you have spontaneous preterm labor, and we do not know the cause. Uh, Infection could be one of them. The second is when the woman's membranes rupture, PROM, as you call it. Then that is the second big group, and third big group is the iatrogenetic. We have to induce labor either because of the mother's reason or the fetal reason. Whenever we have infection in the mother, one thing is that often it's not obvious. The chorioamnitis, frank clinical chorioamnitis is much, much rarer. Often you tend to have subclinical infection. And if it is the baby is born in the setting of PPRM, then it's easier. But because you can suspect infection to be a cause, but in spontaneously preterm labor, it's really very difficult to appreciate whether the infection is there or not there. So as a matter of routine, we need to be very, very vigilant for early onset sepsis, which means the sepsis that is occurring within 72 hours. This is believed to be coming from maternal vaginal tract, so therefore considered to be vertical infection. But our studies have shown that that's not the case in totality. But when we monitor the baby and when we find signs and symptoms suggestive of sepsis, then we'll have to act accordingly, because we are really very scared of early onset sepsis, because compared to the late onset sepsis, it tend to have much higher case fatality, and it comes rather dramatically. And often the baby would have shock and management would become very, very difficult.
So I think it's very important that we recognize the maternal infection, act promptly, and take the prompt thing. And of course, I think we've seen that. I'm sure we will be asking your experiences over the decade that you've seen, how the trends of outcome and neonate have. But some antenatal practices which you definitely feel have left an impact and have improved neonatal survival and have reduced the complications. I just want to hear, but you can really say, yeah, there is one thing is evidence and there's other thing is experience, and which is something which has really left an impact and which you feel has made a difference in the last 10 years of seeing these newborns come. What do you think?
Absolutely. And very, very critical. The care of the mother is very, very critical for the ultimate survival of the baby and even long-term outcomes. And if we see visible things in our experience, one is the antenatal steroids. That has been kind of a miracle. The second is overall antenatal care, adequate number of visits and good counseling, good nutrition, family support, psychological health. These are something that are very, very important, translate into much better outcomes. And in this context, I think the recent WINS study is very important. And I'm quite sure some of you must be aware of that study. And here, the study focused on care of pre-pregnant women, girls basically, who were intending to become pregnant, care during pregnancy. And the elements were that you take care of nutrition, give more when there is malnutrition, treatment of anemia, and treatment of sexually transmitted infections, and psychological health. Almost one third to half of these girls and pregnant women tend to have psychological issues. So if you take care of that, then the prematurity incidence decreases by almost 20%. And that's very, very remarkable, I would say, because till this time, till this study, we carried an impression in terms of evidence at least that preterm birth is not preventable. This is and if you look at the studies, there was preterm reduction studies, but there was not much on preterm prevention because we believed that preterm cannot be prevented, but actually it can be prevented. Great care of the mother can prevent preterm birth, and even it can cause the frame shift. So 28-week baby can become 29, or 29-week can become 30-week, and so on and so forth. And that makes huge difference to the baby's health. So therefore, and I believe that, more than us neonatologists, it is you as obstetrician and the custodian of mother's health, pregnant woman's health, who play much bigger role. And in that backdrop, this conversation becomes so important, and it breaks that silos. And it is very essential that we break these silos and have that conversation going on and keeping mother at the center, not only during antenatal and intrapartum period, during postnatal period also. When you have mother being available, and we have another piece of evidence, in which is immediate KMC, that you bring the mother in the NICU and sees the custodian of the care, some of the care is shifted to her, then the mortality decreases. And you can say that neonatology has been on the forefront in that regard, that in cardiac ICU the attendants are not allowed. Here we would have mothers very welcome. We welcome them with open arms, and the other family members as well. And it does not increase infection, it actually reduces the infection. So the obstetrician and neonatologist, they really need to work hand in hand for the optimum care of the preterm, prevention as well as care.
I think you really brilliantly brought out most of the points. But then I think I just want to ask you, what do you think, or how would, because at most centers would not be, how do you think self comes in the picture, the use of something like, has it made an impact? Because we've been using it in tertiary hospitals, may not be there, but how do you see the benefit when it's an extremely preterm? Maybe do you think that helps in the longer neurodevelopmental, complications, any reduction with them? Because as a
Now,
protocol, we do give
you asked the question again, ma'am. I didn't get it.
the use of magnesium sulfate as we give to a mother with preterm
Magnesium sulfate.
extremely.
Yeah,
How do
right.
you feel that? Because again, that is a newer armamentarium that we have a newer
Yeah,
modality to
right.
sort of help
Mhm,
these
mhm,
babies. How do you perceive
yeah,
that as?
mhm. So now there is level one evidence which says that if you have you know less than 32 weeks or less than 31 week woman going to preterm labor, and you give mother max self, then that improves the neurological outcome of the neonates, and without any side effects. So this is something that should routinely be practiced. But that is off the shelf kind of thing. That more important is holistic care. Uh, you know, max self, or for that matter, any single modality is not going to make difference. It's the everything. You need to look at, if you were to make, and many of you must be making great dinner and lunches. This is like having all the ingredients in right quantity on right time. And just adding a sophisticated spice is not going to make a difference. You have to do, if not everything, most of the things, to be able to have optimum outcome. And then that is true for the care of the mother, and that's true for the care of the babies also. And the vertical intervention, the single intervention, is not that important, but we have self level one evidence, so that should be part of our armamentarium for the care of preterm labor.
So I think very well pointed out, antenatal steroids, care of the mother, kangaroo mother care, all these. So these are what I think we are fortunate to get the privilege in tertiary and, high-end level three nurseries. What is the ground reality? Do you think these practices are followed in the community? Or how much is because since you are on the network of, and you have a very, very, good vision, and you have a good, exposure to meet a lot of your, colleagues whom you interact looking after district hospitals. How do you really feel is the availability of all these, you know, interventions in the community?
So, there is a huge variation with respect to anything or everything in our country. You move one corner to the other, or one hospital to the other, or one state to the other. There is huge variation in the care of mother as well as the babies. And not so good performing states, you will find that the programs and policies are there. They are similar across the board. And India has done extremely well in that regard, that you have all the interventions, proven interventions, have translated into policy, whether that's a government sector or the private sector. For the private sector, I'm quite sure Fogsi is at forefront in making those guidelines. So those guidelines are there. You take anti-cancer steroids or Mexel for psychological health, or number of antenatal checkups, screening, and so on and so forth. And same is true for our neonates. But if you look at the main problem is the no-do gap, that we know things, but we are not able to translate them to action. And what matters is then what the mother is getting and what the baby is getting. And it's not just, checking the box. You can do thing A, but if the requisite quality is not there, quality in terms of, technical quality, but also wrapped in, the right emotions, that empathy, that compassion. So unless that is there, things do not translate into good outcomes. So there is huge variation, coming to the question that you posed to me. There is huge variation across the facilities, government sector, private sector. At many places, there is too much being done. There are places where there is too little being done and too late being done. So that is the challenge that we face as a country, as a society, I would say, not as a country, as a society. Um, we fail as providers, we fail as families, we fail as society. The mothers need to get their due care. I think that is something which is very, very important.
So I think you've been really, really passionate about, and I can see how passionate you are for the quality initiatives that you've taken at AIMS and many more places. Now, I know that is, as you rightly pointed out, that we are a huge variation, but in a setting where you're setting up an ICU, maybe at a district hospital level, where you may not have the privileges of tertiary ICUs like AIMS or at the most corporate, what would you think would be the low cost, but yet a very high impact newborn care, which I think a pediatrician can offer? Because every district hospital may not have a super specialist neonatologist being posted. And I think that's one of our challenges in terms of getting the right human resource. But what do you think would be some of those, basic essentials which should be there in the district hospital, which can take care of, before you think, yeah, the reality, the gold standard should be every NICU in every district hospital. What do you think about those kind of interventions?
Yeah. So currently in our, if you look at the government paradigm, the national health missions paradigm, which looks after the mothers and newborn care in the country in a tiered approach. So the district hospitals are supposed to have a special newborn care unit, SNCU as we call them. There are nearly 1,000 of them in the country, catering to nearly 20 lakh babies every year. And majority of them are preterm babies. Of course, asphyxia is also there. So what we need is one, again and again, I'm coming back, coming out of neonatal unit. That what happens in the labor room, we need to focus on that. The mothers are coming there. Are they getting right kind of treatment? Even I would move to the antenatal clinics, whether the right kind of care is happening or not, if there is an high risk pregnancy that's being identified or not, and then care during labor and then care at birth. This is all that's happening in the birthing rooms. Once the baby comes to the SNCU level 2 care, what you need is set of simple care. You need thermal care, temperature, thermal protection of the baby in form of radiant warmers. You need a nice and clean space, physical space, so that there is no overcrowding. You need, simple monitoring things like pulse oximeter, but more importantly, right kind of feeding practices that we save the baby from unnecessary IV fluids and antibiotics and investigations. Even you prevent, unnecessary things happening to the babies. And with optimum feeding, involvement of the family, providing KMC, their own mother's milk, and getting involved in developmentally supportive care. Infection control and prevention is something which is very, very critical and which requires high level of commitment by the providers. So if we take care of these basics, and I would like to add one more thing, is that because prematurity related complications are the most common cause of death, 40% of them. So having an optimum CPAP for mild to moderate respiratory distress and possibly with surfactant would be very, very helpful. So if you have this simple care which can be provided by the district hospital or level 2 unit, even in private sector by a pediatrician, then majority of these babies would survive to the extent of 90 to 95%, I would say.
Yeah. And I think you rightly pointed out that there's a mother is at the center of care. Do you think any lifestyle factors, in the antenatal, which could really influence anything in the lifestyle that we should take care of the mother or the, pregnant mother, which could help her influence and prevent the chance of her going to preterm birth, which you feel should be really highlighted and we should tell to the public, which are important?
I would say that rather than lifestyle of the mother, the lifestyle of the society is perhaps more important. That even if you look at, in 2025, we have nearly 10 to 15% of pregnancies happening in teenage. And in some pockets of the country, this number may be 30%. A huge problem. You have a child and who's bearing another child. It's such an enormous responsibility for which that small girl is not at all ready. So, we begin there, and care of the adolescent girls, something very important. If you look at their anemia, 50%, 60% of them are anemic. You look at their body weight, they must weigh 35 or 40 kg, many of them. You look at their stature, their short stature because of the intergenerational malnutrition, though you can't do anything, but at least take care of the nutrition of this girl. And interpregnancy interval, that there are not too many pregnancy and too early pregnancies. And then in the individual lifestyle level, taking healthy diet, nutrition, avoiding different kind of toxins, like tobacco, or hard physical labor, or the stress, etc., avoiding sexually transmitted infection, or getting treatment avoidance may not be possible. So if those things are taken care of, then they influence the prematurity rate as well as the outcomes of the premature babies that are born.
So certainly you really highlighted beautifully, some of these causes and factors we as obstetricians and jointly all the healthcare providers, be it at any level, have to really focus. And I know you wonderfully described how, the kangaroo mother care and care of the newborn. But then I think there is an element of the family support. I think we are fortunate that in India, we do get good family support. How do you see that kind of a family support, be it on the emotional front for the mother coming to help her come over the challenges which are there, both physically, emotionally? How do you feel that is playing a role in you know averting and
You
improving
know,
the outcome?
massive role, massive role. And the family, be it husband or sister-in-laws or brother-in-laws or mother-in-law or the mother or the father, everyone has to be supportive of the woman. To begin with, she has got huge amount of emotional stress and psychological stress. And there is good likelihood that she suffers from her own health issues, because that might have precipitated the preterm labor. And now you have the physical challenges and the emotional challenges, and then, enormous amount of stress that it poses in terms of the expectations from the mother. So just to give you a small example, that we ask the mother to express milk within first hour of birth to be able to maintain lactation. Ask a mother who has just delivered, particularly by C-section, you know, is it easy for her to do it? Unless you have family by the side, and that to a supportive family, not a family who's unsupportive and unempathetic, then you would not be able to, mother would not be able to express milk. Then we tell that, come and sit with the baby. And simultaneously, we ask her that, have 8 hours sleep. You know, how is that possible without the support of the family? Or, nutrition. When it comes to nutrition, she needs good, right kind of nutrition. So again, you need someone whom she can talk to. She can share um, her fears and what she worry about. She Everyone has, a very good sense. We all humans have very good sense that what's going on. We may not know the technical details, whether the baby has got RDS or, sepsis or asphyxia or intraventricular hemorrhage or PDA, but they have a very intuitive sense that what's going on with the baby, just by looking at the baby, and maybe perhaps, the behavior of the people around the baby, the provider's behavior, that something wrong or everything is going on well. So that's a very, very stressful environment, and the woman has to be supported by everyone. You need a lot of empathy and compassion.
Thank you, I think, for bringing this aspect, because I think this is less talked and often not discussed when we come to forums. So simply, I think before we really wrap up, one or two questions it could be, because you're at helm of so many policies that are being made at the national level. What policy action do you think at the national or state levels that could really help us reduce preterm birth, or maybe which you feel should be there in place and improve the outcomes at the grassroots and then at the tertiary levels? Ramesh, you're muted, Ramesh.
Yeah, right. So I said that, as I said, in terms of policies, we have them in place. 90% of 75% of preterm birth, I would say even more than that, can be salvaged very easily. The issue is that how do we take care of this no-do gap? And that requires huge commitment by everyone. If we talk of the care at the level of hospital, commitment in terms of making sure that the infrastructure is there. And infrastructure is there, but sometimes you would have some gap here and some gap there. So those are taken care of on ongoing basis. Simple and the skills and commitment of the providers, nurses and doctors, supply issues, and having that mindset that the family and the mother are the partners in the care, not having that um, um, that approach wherein we are someone and she is just no one. So getting out of that mentality and making her partner, and putting her at the center stage. Uh, at many places that happens, but at many other places when we talk, then it sounds very simple. But then at many places, these are big challenges. People are not able to overcome these small things. So we should focus our energy on filling this no-do gap, improving the quality of care. We make sure that what we know reaches to each and every mother and each and every baby with the requisite quality, with empathy, with compassion, as I said. That is something we should focus on. And as the members of Foxy, I would really call upon you that when you do rounds, then be in the include NICU also in your rounds. That brings in different kind of energy and you know involvement and the connection, which is something which is very, very important.
So
Yeah, these are the things that we should focus on.
I think as we look at, I think we'd probably strengthen the training right from the beginning, right? When we're training our postgraduates, for that matter, right there, doing the undergraduate, getting that, that kind of a temperament of a joint, teamwork between obstetrician and pediatrician, and of course our nurses and our social workers. I think if we put our strength and energy in training them in that way, I think we could probably create a model kind of care. So I think it has been really wonderful, but I won't let you go off the podcast before I ask, and I will really enjoy asking this question because I've had brilliant, guests on my podcast, leaders in their own walks, in their own field, and we see you as a leader or most brilliant neonatal discipline unit of the country. So I would just want to hear you. What you think makes a leader? As you lead such a big team, and not just your team of pediatrician, neonatologists, your nurses, your expanded network of research across. So, what is your definition of a lead, and how would you say to the young aspiring viewers and our upcoming generation, what should they chase to be good leaders?
Great question, ma'am. And you know, I can have my opinion only. I don't know what's the right or wrong. And recently we had one of our students doing oration in the IJP symposium, and he provided one definition of leader, and that resonated with me. The leader that he defined was that leader is someone who, of course, mentors his team until a point that they don't need you. So a leader is someone who is standing behind the people till the time they need it, and after some time they don't need him. That would be my guess, the most important ingredient of a leader. And then second most important thing is that we do not control the minds of young people. I think that is something which is very, very important. We let their creativity flourish, create an atmosphere where they can express their opinions. Uh, Let them commit the mistakes that they wish they would commit. Let them explore themselves, and let them explore the environment, and give them a canvas which is wide, and where they can really manifest themselves. I think that would be my definition.
I think that's a brilliant answer that you've given. Finest answers I could get. I'm sure to all the young viewers who will be watching it now or are watching currently or later, I think that'll be the most inspiring message comes. So thank you so much, Dr. Ramesh, for being with us on our podcast. And I think this month of prematurity awareness should go a long way in giving the message of how much we can do as a team, and what empathy and what compassion can do to our mothers and the babies. Thank you so much for being with us. Thank you so much.
So apart from treating with our mind, we treat our patients with a lot of heart also. That's equally important, maybe more important.
Thank you. Thank you so much.